Usually when we talk about medical procedures, there's this underlying expectation of precision,
Right.
like it's engineering or something. You break your arm and the X-ray shows that jagged white line, and the
Yeah.
doctor just points at it and says, there it is. We fixed that.
Right. It's very binary.
Exactly. But how do you measure something that is entirely invisible
Yeah.
and totally subjective? I mean, it's kind of like trying to objectively score how cozy a room is, or
Mhm.
like how much confidence a tailored suit actually gives you.
Yeah, that's a great analogy.
Because in medicine, when patients undergo labial majora volume restoration, whether that's through fat grafting or hyaluronic acid fillers, doctors, they can't just use a tape measure to gauge success.
No, they really can't.
They are tasked with measuring human emotion and self-esteem and intimacy. So welcome to the deep dive.
Today we have a really fascinating stack of sources in front of us.
We do.
We've got clinical trials, we have excerpts from Aesthetic Plastic Surgery in the European Medical Journal.
Right. And all these exhaustive developmental records of patient-reported outcome measures.
Yeah, the PROMs.
Right. So our mission for the next bit of time is to guide you through this intersection of objective science and subjective human experience. We're going to explore the specific psychosexual evaluation tools that doctors use to quantify the unquantifiable.
It really is. I mean, it's the ultimate diagnostic challenge when you move away from treating a pathogen or, repairing a broken bone, like you said.
Yeah.
And you step into this realm of subjective physical comfort and sexual well-being. The standard medical metrics just kind of fall apart.
Right, because there's no blood test for comfort.
Exactly. And that is why the medical community has invested so heavily in developing these TOMs, patient-reported outcome measures.
Okay.
We're looking at a recurring theme across these clinical trials today, and that is the sheer sophistication of these diagnostic questionnaires.
Yeah, they're not just simple surveys.
No, not at all. For example, researchers like Dr. Ann Klassen, she has this extensive registry of COM development, and that includes highly specific tools like the Labia Q. These questionnaires are actively shifting the focus of these procedures away from just pure aesthetics and heavily toward measuring a patient's overall quality of life.
Okay, so let's unpack this a bit, because calling a questionnaire a diagnostic tool, I mean, it makes it sound like a wrench or a thermometer.
Yeah, it sounds strange.
How do these PROMs actually work in practice? Like, if a patient comes in for labial majora volume restoration, how on earth is a doctor using a piece of paper to determine if the procedure was a medical success?
So I think the best way to understand them is to look at what they are intentionally avoiding.
Okay.
The goal of these tools is absolutely not to define an anatomic ideal.
Oh, okay.
In fact, the medical literature we're reviewing today explicitly warns against that.
So there's no perfect picture they're trying to match.
Right. When the texts say in the absence of pathology, which is really just a clinical way of saying unless there's an active disease or some kind of traumatic injury,
Right.
there is no single correct ideal for female genitalia.
Wow, okay.
And implying that one exists can actually be deeply harmful to patients because there is just a massive physiological range that is perfectly normal.
That makes a lot of sense.
So these tools aren't measuring a patient against some textbook image. They are measuring a delta.
A delta meaning like the change?
Exactly. They capture the patient's internal shift from a state of distress to a state of comfort.
So you're measuring the distance the patient traveled emotionally and physically, not really where they landed on some universal map.
Exactly that.
And if we're measuring an internal shift, it seems like we have to start with how a patient views themselves, like even before we look at how they interact with a partner.
Absolutely.
And we see this in the first major ruler of self-image in our sources, which is the FGSIS.
Yes, the Female Genital Self-Image Scale.
Mm-hmm.
This is really the foundational tool here. It's a 7-item questionnaire that uses a 4-point Likert scale.
A Likert scale being that classic, like, strongly agree to strongly disagree format.
Yeah.
Like you'd see on a customer satisfaction survey.
Spot on.
Mm-hmm.
Sounds incredibly basic, right? But it is a highly validated way to track psychological changes.
So what kind of questions are on it?
So the survey asks patients to rate statements like, I feel comfortable letting a healthcare provider examine me.
Oh.
Or I feel positively about my genitals. And the total score for this ranges from 7 to 28.
with a higher score indicating a more positive self-image, I assume.
Exactly.
And we see it used effectively in the actual clinical data, too. Like, there's this one study in our stack on a technique called 360 genital fat transfer.
Right. The autologous fat study.
Yeah, they followed 97 patients who underwent labial majora augmentation using fat taken from their own bodies.
Mm-hmm.
And before the surgery, the mean FGSS score for these women was 17.7.
Okay.
But a year post-surgery, that mean score jumped to 22.2.
That's a big jump.
It is. It's a measurable statistical leap in how these women viewed themselves. But I have to push back just a little bit here. Because if I get a great new haircut, I feel amazing about how I look.
Right.
But my brain doesn't suddenly process math faster, you know?
No, it doesn't.
So does just feeling better about one's appearance actually translate to physical function and intimacy? Like, how does injecting volume physically change how the body operates?
So this raises an important question, actually. And it really is the crux of why these metrics go far beyond just aesthetic confidence.
Okay.
Because aesthetic confidence is only one part of the equation here. To measure the physical mechanics of intimacy, doctors rely on another incredibly detailed tool.
Which one is that?
It's the FSFI, or the Female Sexual Function Index.
Okay.
And this scale doesn't ask about appearance at all. It is 19 questions spanning 6 distinct domains of sexual function.
Which are?
Desire, arousal, lubrication, orgasm, satisfaction, and pain.
Wow, so it is much more mechanical.
Very mechanical.
But how does volume restoration actually impact something like arousal? I mean, physically.
It really comes down to structural support. When the labial tissue atrophies or loses volume, it essentially loses its cushioning effect.
Oh, I see.
So restoring that volume with hyaluronic acid fillers or fat grafting mechanically changes the local tissue environment.
Okay.
It adds cushioning, which alters local blood flow and nerve engagement.
Yeah.
And it drastically reduces physical friction.
That makes sense.
Right? So by creating a better physical environment, it allows natural physiological arousal to occur without the active blockade of discomfort.
Got it.
And what's vital about the FSFI is that it has a scientifically established magic number to track all this.
That magic number.
Yeah, a full-scale score of 26.5 or lower indicates clinical sexual dysfunction.
Oh, wow.
There's a very strict cutoff point used by researchers globally.
So it's literally like a check engine light for sexual health.
Exactly.
If you're below 26.55, the warning light is flashing on the dashboard.
Yeah, that's exactly what it is.
And the data from the sources on this is just striking. Like if we look at the Isolane study.
Oh, yeah, the HA filler study.
Right. This was a prospective multi-center study involving over 70 women who received hyaluronic acid filler injections to restore volume. And the sources note that before treatment, most of these patients had baseline FSFI scores below that 26.55 cutoff.
Right, so they were officially in the category of clinical sexual dysfunction.
Exactly. But after the volume restoration treatment, over 75% of those patients surged past the 26.55 mark.
They moved entirely out of the sexual dysfunction category.
It's incredible. The procedure essentially turned that warning light off for the vast majority of the patients.
Yeah.
And this wasn't just some brief spike either, right? The study tracked them for 52 weeks.
A full year.
A full year. And the median scores stayed above that cutoff the entire time. They saw significant improvements across all those individual domains you mentioned, like arousal, lubrication, orgasm. It really proves that the physical volume restoration was directly improving the functional mechanics.
It really does. Improving function is a massive win. But sexual health and physical comfort, they aren't just about adding positives like arousal or satisfaction.
Right.
It's equally about removing active negatives.
Right.
We're talking about erasing distress and literal daily physical pain.
The ripple effect of the procedure, basically.
Yes, exactly.
It's not just about the bedroom. It's about going for a run or sitting in a chair without being in actual pain. And the Isolane study captured this beautifully using an NRS, which is a numerical rating scale from 0 to 10.
Right.
They asked patients to rate symptoms specifically related to tissue atrophy. And before treatment, the average score for irritation and burning during daily life was a 2.9 out of 10.
Okay.
By week 52, it had dropped to a 1.0.
Wow.
Yeah, and irritation during sports dropped from a 3.1 down to a 1.0. Itching dropped from 2.5 to 0.9.
That's huge.
It really is. When you remove that constant low-level physical friction from someone's daily life, the psychological relief just has to be immense.
It is immense, and we can actually quantify that relief too.
Really?
Yeah, to measure that psychological burden, researchers use the FSDSR,
Okay, which is...
the Female Sexual Distress Scale Revised. And they use it alongside the SCOLO-F, which is the Sexual Quality of Life Female Tool.
Okay, so more acronyms.
Lots of acronyms. But what's fascinating here is the mathematical relationship between the mind and the body that these scales actually reveal.
Okay, how so?
So when researchers plot the scores of the Genital Self-Image Scale, the FGSIS,
The first one we talked about.
right, when they plot that against the distress scale, the FSDS, they find a direct inverse relationship.
Oh, interesting.
Yeah, for every 1 unit rise in a woman's self-image score, her psychological distress score predictably drops by 1.24 units.
Okay, so I see the neat ratio on paper. But why does that specific math matter to a normal person? Or even like a doctor sitting in a clinic with a patient?
Because it proves the link between body image and psychological pain is not random. It's predictable.
I see.
If a clinician can use an intervention to improve a patient's physical self-image score by a specific margin, they can reliably forecast a massive corresponding drop in psychological distress.
It gives them a blueprint for treatment, basically.
Exactly.
Well, here's where it gets really interesting, I think. Because we can see that exact blueprint play out in real time when we introduce objective physical measurements right alongside the psychological ones.
Oh, right, the EMJ study.
Yeah. The study published in the European Medical Journal, they looked at females experiencing vaginal laxity and sexual distress. And they treated them with dermal fillers, but they didn't just ask them how they felt on a piece of paper. They used a device called a perineometer.
Right, the Labori Peritron 9300.
That's the one.
It is a highly sensitive piece of diagnostic equipment. It's essentially a conical vaginal probe with an air-filled silicone rubber sensor. So when the pelvic floor muscles contract, the sensor measures the occlusive pressure. It provides a purely objective raw data point for muscle strength and tone.
And what's it measured in?
It's measured in centimeters of water, or CMH2O.
Okay, let me make sure I'm picturing this right. It is essentially a grip strength tester, but adapted specifically for the pelvic floor.
Yes.
And the CMH2O is just the unit of pressure it reads out, kind of like checking the PSI on a car tire.
That is the perfect analogy. It is a completely objective measurement of force.
Okay, so you have this highly objective measurement of physical muscle tone on one hand, and then the highly subjective FSDSR emotional distress questionnaire on the other hand.
Exactly.
And before the intervention, the perineometer measured an average muscle tone of 23.25 CMH2O. And the patient's distress scores were at a highly distressed 29.65.
Right.
Following the dermal filler therapy, the objective muscle tone increased significantly to 27.56 CMH2O. But the subjective distress score,
It plummeted.
it really did. It dropped from 29.65 all the way down to 15.45.
Wow.
Yeah, when you physically fix the tissue, the structural support returns. And when that physical laxity and pain stop, the mental distress just evaporates.
It perfectly illustrates the feedback loop between physical structure and mental state. It's amazing.
But wait, if fixing the physical tissue cures the mental distress, what happens if the distress isn't actually rooted in the anatomy? Like, how does a doctor know they aren't about to perform surgery on someone whose pain is entirely psychological? Is there some kind of safeguard for that?
Well, you've hit on the core ethical and medical challenge here.
Yeah, it seems risky.
It is. Because subjective satisfaction is the ultimate goal, clinicians have to screen for psychological conditions that no scalpel or syringe can cure.
Right.
And the most critical of these is body dysmorphic disorder, or BDD.
Right, BDD. I mean, we all have that thing we fixate on in the mirror, right?
Sure.
A crooked tooth, a weird freckle. We zoom in on it. But body dysmorphic disorder takes that normal human quirk and just dials it up to a debilitating obsession.
Exactly that. A patient with BDD has an overwhelming preoccupation with a perceived flaw in their appearance that is often totally unnoticeable to others.
Okay.
So if a surgeon operates on a patient with untreated BDD, the patient will almost certainly remain dissatisfied after the procedure.
Right, because the body wasn't the issue.
Right, because the root of the distress is neurological, it's not anatomical.
And just like we have tools to measure satisfaction after the procedure, we actually have tools to screen for dysmorphia before it.
Yes, we do.
The sources highlight 2 specific questionnaires used as safeguards. There's the GAS, which stands for Genital Appearance Satisfaction Scale,
Hmm.
and the COPSL, the Cosmetic Procedure Scale of Labia.
Yeah. The GAS is particularly revealing in triage. It's an 11-item questionnaire scoring from 0 to 33. But unlike the self-image scale we discussed earlier, the GAS is reverse scored.
Yeah.
A higher score on the GAS indicates greater dissatisfaction.
Oh, okay.
When researchers validate this scale, the numbers are just stark.
Like how stark?
Well, a control group of women, so those just going about their lives, not seeking any cosmetic intervention,
Right.
they average a score of around 6.7. But patients who are actively seeking surgery often score around 38.7 when it's adjusted for the scale limits in validation studies.
Wait, 38? That is a massive delta.
It's huge.
You're looking at a score nearly 6 times higher than the control group.
Exactly.
It just highlights how heavy a psychological burden these patients are carrying when they walk into a clinic in the first place.
It does. And this is where the COPSL acts as a safety net alongside it.
Right.
It's specifically designed to flag the hallmarks of body dysmorphia. So if a patient's COPSL or GAS scores indicate severe dysmorphia, meaning their internal distress is entirely disproportionate to their actual physical anatomy or function,
Yeah.
the medical route dictates a pause.
They just don't operate.
Right. The most appropriate intervention at that point is psychological support and therapy rather than surgical intervention.
That makes sense.
Yeah, the goal is to ensure the treatment matches the actual source of the pain.
It's really a profound shift in how we view medicine. I mean, you aren't just treating a physical symptom anymore. You are triaging the entire human experience.
Absolutely.
We started this deep dive talking about how hard it is to measure the invisible. You know, how you can't use a tape measure to quantify confidence or comfort.
Right.
But what we've seen is that through this stack of carefully calibrated questionnaires, from the FGSI measuring self-image, to the FSFI tracking functional arousal, to the FSDSR measuring mental distress, the medical community has built a bridge. These PROMs, they act as a literal bridge between the physical realities of labial majora volume restoration and the complex human emotions of confidence, intimacy, and just pure pain relief.
They really translate the subjective into the empirical. By tracking these scores, a clinician can see exactly when a patient moves out of clinical dysfunction, exactly when their daily physical irritation drops, and exactly how their self-image improves.
It's right there in the paper.
Yes, it validates the patient's lived experience with hard, trackable data.
So what does this all mean? I mean, whether you are analyzing clinical data for work or you're just endlessly curious about how human beings tick, this is just a profound reminder that the mind and the body are not separate entities.
Not at all.
We now have the rigorous, peer-reviewed data to prove that how we feel about our bodies is inextricably linked to how we function within them. When you restore physical comfort, you basically unlock psychological freedom.
And if we connect this to the bigger picture, knowledge is only truly valuable when it's applied, right?
Absolutely.
Understanding these metrics forces the medical field to evolve. It demands that clinicians treat the whole patient. You cannot simply inject a filler or perform a fat graft and call it a success based purely on a visual assessment.
Right, you can't just look at it.
You have to ask the patient how their life has changed. By utilizing these psychosexual evaluation tools, medicine becomes less about fixing a localized physical issue and way more about restoring a person's overall quality of life.
Well, it really is a revolution in patient-centered care. But it does leave us with one final lingering thought for you to mull over.
Okay.
Because as we've seen today, these psychosexual evaluation tools like the newly developed Labia Q, they're becoming incredibly sophisticated at mapping the human mind.
Oh, yeah.
At the exact same time, artificial intelligence is getting exponentially better at analyzing complex data sets.
Oh, I see where you're going with this.
Right. So will we reach a point in the near future where a simple AI-driven questionnaire can perfectly predict the exact physiological intervention a patient needs, like diagnosing the physical purely through the psychological before a doctor ever even conducts a physical exam?
It is a fascinating frontier.
It really is.
Yeah.
Thanks for joining us on this deep dive.